Hi everyone, my name is Stephen Fajeris and I'm with the Emergency Medical Minute audio and event team. A few weeks ago we had the opportunity to attend the EMS Association of Colorado's annual conference, where we had a booth where we connected with emergency medical providers, shared resources, and had some great conversations with those in the field. While we were there, we recorded a series of quick medical minutes and interviews with some incredible doctors, paramedics, and presenters, covering a wide range of EMS topics. It took us some time for approval in the process and finalize everything, but we're excited to finally share these conversations with you. In this episode, you'll first hear from Colonel Dr. Stacy Shackelford, a U.S. Air Force trauma surgeon and director of the Joint Trauma System, who shares insights on prehospital trauma care, the role of early transfusion, and what the military has learned about reducing preventable deaths. Then we have Dr. Sean Keenan, a retired Army emergency physician and EMS doctor, who talks about prolonged field care and how military trauma lessons apply to civilian EMS and the importance of managing critically injured patients in difficult environments. Then we have paramedic Alan Moreland from Denver Health and Denver's Support Team Assisted Response Program, who explains how alternative EMS response teams are reshaping mental health crises in response to 911 calls and alternative EMS. Then we have Dr. Chris Tems, an emergency physician specializing in ECMO, discussing how this advanced resuscitation technique is revolutionizing cardiac arrest treatment. Then we have Kara Napolitano from the Laboratory to Combat Human Trafficking, who sheds light on the prevalence of human trafficking in EMS and how human trafficking presentations may not be so prevalent or easy to recognize. I'm Steven with the Emergency Medical Minute audio team, and I'm here with Colonel Shackelford. And she's with the Joint Trauma Division with the U.S. Air Force Academy. And thank you so much for being here. And she just gave a brilliant keynote speech on Joint Trauma Forces and different information about trauma. And if she'd like to give tidbit and educational pearl about trauma.
Okay, so a couple of things that we've been looking at with the Joint Trauma System have led us to believe that the biggest opportunity to save lives in trauma is before they get to the hospital, where 90% of the deaths occur. And the vast majority of those, at least in the military population, were from bleeding. And so about 10 years ago, the DoD did a study looking at that, and it caused us to do a big pivot, really investing in pre-hospital trauma care to improve the ability for our medics to stop bleeding and then to transfuse blood. So those are probably the two most important changes in surviving traumatic injury in the military. I will say that since that time, there have been a number of studies that have come out that show that pre-hospital transfusion doesn't make a difference. And so one of the things I sort of talked about in detail this morning is the importance of time and time of injury to time to life-saving interventions, how much time has gone by. And it seems pretty obvious, but life-saving interventions provided too late do not improve survival. And on the military side, we did an analysis that showed that about 30 minutes is the time in our patient population. If you get transfused after that, it doesn't improve your survival. Either you're already too far gone or you didn't need it. And so our goal is 30 minutes on the military side. A lot of the civilian analyses that have come across have not taken account of that time frame. And in fact, some of the studies where they proved that there was no benefit, the actually average time to transfusion was nearly an hour. Anyways, I think there's a lot to be learned from the military lessons, and I think there's a lot we can do to improve our analyses of pre-hospital interventions. And sometimes when you think of something that seems really obvious, like they're bleeding, give blood, if you read a study that proves the opposite, you have to really, really think about what's going on with that study.
Thank you so much.
Brian here at the 2024 Emsac conference in Keystone. I have with me Dr. Sean Keenan, who did a presentation on prolonged field care. Take it away.
Yeah, hey, Sean Keenan, thanks for having me here. Listen to the podcast. Very cool. I love what you guys are doing. So we talked about prolonged field care. I'm a retired Army emergency physician, also an EMS doc. And we basically came up with a bunch of guidelines because we had this problem in the military where we couldn't move patients out to surgical facilities. So we had to come up with a way that we were going to manage serious and critical casualties in austere environments. We spun off a nonprofit company called Specialized Medical Services. Specialized specialized medical standards, and austere emergency care was the curriculum. We started teaching it in rural Colorado, and what we found was that the lessons that we were teaching in the military absolutely translated to the non-military folks and the professionals in paramedicine, EMTs, even some first responders. And so I was able to kind of share that into an audience here at the Emsac meeting. So really excited to see where this goes. If people want to check that out, we have a website called austerecare.org. Some people might be familiar with the Prolonged Field Care podcast and website. That also falls under our nonprofit company. So just want to try to get the good word out as to what we're doing and hopefully get after solid education and training for pre-hospital folks.
We're here with the Denver Paramedic Stars to share a little bit about what they do and how it works.
Sure. My name is Alan Moreland. I'm a paramedic with the STAR program, which is an acronym for Support Team Assisted Response, and we're an alternative response program that partners EMT or a paramedic with a clinical social worker to go out and answer 911 calls. Basically, we answer calls that police or ambulances traditionally would answer, but we can go and solve problems, mental health problems, kind of on our own. Kind of takes the pressure off the system. We really believe in kind of a trauma-informed approach to everybody that we talk to. Our vans are equipped with the ability to transport people. Also, we carry a lot of harm reduction things with us, phenol test strips, Narcan. We also carry warm weather clothing, offer people food and resources. The great thing about alternative response is not only are we lightening up kind of the pressure off of the system, but every call that we go on, we are kind of diverting resources, important resources, to get people the right care that they need. So if there's a mental health, a suicidal party, a mental health crisis, we can go and intervene without the need to have police officers or an ambulance respond. And that's typically how the system is built right now. So what we're trying to do is just offer the right resources for the community and get them referred into services perhaps in a more long-term capacity. So yeah, alternative response programs now are kind of the wave of the future, I think, as far as mental health and medical response.
Any education or any advice you'd give to anyone in the streets or working for how to handle that kind of stuff?
Yeah, I mean, I think that rethinking how we do things just kind of reduce the trauma that's involved in a lot of things that we do and we see, not only for the first responder, but for the public too. Like, there's a lot of trauma involved in policing and how traditional policing has happened. There's a lot of trauma for some people out in the community about being transported by ambulance, especially in the mental health realm where, a lot of times your rights are taken away from you. That's what's great about alternative response in the STAR program is that we have the time and the resources and the expertise to understand and follow up and get people really the resources that they need.
Thank you.
Thank you.
Brian here live at the 2024 Emsac conference in Keystone. I have with me Dr. Chris Tems, who just gave an incredible presentation on ECMO usage in patients who underwent cardiac arrest.
Thanks so much. It's great to be given the opportunity to speak about ECMO, which I think is truly the future of cardiac arrest resuscitation for patients who are failing traditional therapy. And so we are talking about ECMO largely because of a number of different trials, the largest of which was the ARREST trial published by Dimitri Yiannopoulos. And this showed that they had 43% neurologically intact survival in a patient population that had almost an hour of CPR. Now that and many other studies has changed kind of the paradigm of how we're managing cardiac arrest at our institution. And now we're looking at deploying ECMO, VA ECMO or veno-arterial ECMO, which can fully support oxygenation and perfusion for patients who are in refractory cardiac arrest not responding to traditional CPR. And so far at our institution, we've put 8 patients on ECMO in the emergency department who met our inclusion criteria. And out of that group of 8 patients, we've had 7 neurologically intact survivors, which is an 87.5% neurologically intact survival rate with a group of patients you'd expect to have no survival at all. So our next steps are engaging our EMS partners and bringing more patients to the hospital earlier on in the course of their cardiac arrest to be able to offer this therapy. And we're excited to continue to build the program in the future.
Brian here live at Emsac 2024. I'm here with Kara Napolitano. She just gave a great presentation about human trafficking.
Hi, everyone. I work for an organization called the Laboratory to Combat Human Trafficking, and we travel around the state of Colorado educating first responders and healthcare providers about what trafficking is and isn't. And, one of the main goals of our trainings is to myth bust and really get the word out about what trafficking is here and how it shows up in your work. So what we know is that most healthcare providers have not been trained on trafficking, and that most trafficking victims will show up in a healthcare setting during the time they're being trafficked, because trafficking is dangerous and people get hurt. We see a lot of people, well-intended, smart people missing trafficking. And so we really encourage folks to get a human trafficking training. Labor trafficking is significantly more prevalent than we hear about. We see labor trafficking showing up across the state in construction and agriculture, ranching, and hospitality mainly. And we also see a great deal of sex trafficking of both minors and adults. Most trafficking survivors know their trafficker and are therefore in situations of interpersonal violence or domestic violence situations. So the kind of stranger danger kidnapping scenarios that we see in the movies and on TV are false and kind of lead us to miss a lot of the more nuanced trafficking situations that we actually do see in the state. So if you're interested in learning more about how you can be involved in the human trafficking response as a healthcare provider or first responder, go to our website. It is combathumantrafficking.org, and you can request a training. They are free for your team. We can get something set up either in person or virtual. So we hope that you contact us. Thanks.